Oncology and hematology. First thing what we'll be seeing is massive transfusion. What is massive transfusion? What is the definition of massive transfusion? We call it as a massive transfusion if you are transfused more than 10 units of PRBCs or any blood products. Most of the time it is the PRBC what you'll be transferring for 24 hours. I mean, in 24 hours, if you're transfused more than 10 units, then you call it as a massive transfusion. Or you are transfused 4 units in an hour span, then you call it as a massive transfusion. We usually in trauma cases, it's very easily 4 units you transfuse in an hour's time and it becomes a massive transfusion. What happens when you do a massive transfusion? In massive transfusion, when you transfuse PRBCs, there is dilutional there is dilutional low platelet counts known as thrombocytopenia. There is dilution of coagulation factors, so coagulation depletion will happen. That is a very common complication what you see during massive transfusion. The most commonest complication of a massive transfusion is hypoglycemia. Why does hypoglycemia occurs in a massive transfusion? Because the blood is stored in citrate medium. Citrate toxicity causes hypoglycemia. Usually the hypoglycemia is quite minimal, doesn't require any correction as such. Sometimes the stored cells will degrade. That means the cell will break down into small pieces. So what is inside the cell comes out. Mainly the potassium comes out. So you can expect an potassium release and hyperkalemia in these cases. Again, most of the time, this blood is not stored for long enough for them to degrade and cause potassium release. Blood is stored at a temperature of 2 to 6 degrees Celsius. Why is it? Because it is stored at a certain cold temperature. Use and blood warmers to transfuse it. If you do not use blood warmers and you're directly transfusing from the blood bank at 2 to 6 degrees Celsius, then hypothermia can result in the patient. What happens once you transfuse? What are the adverse reactions what you can expect in a patient with an blood transfusion? This is very important, usually tested in the examination. So transfusion reactions, what happens when you transfuse the blood? There are two main transfusion reactions. One is immune mediated. The other one is non-immune mediated. First, we'll be seeing the immune mediated. In immune mediated, either the presentation will be with fever or the presentation will be with an allergic reaction, like there is a rash, there is a itching which is associated with it. First, let us see the allergic reaction. So allergic reaction can be mild, can be severe. So severe form of allergy is nothing but anaphylaxis what you are having. So this patient can be having an anaphylaxis or just be having a rash like an urticaria associated with an itching. If it's just a rash with an itching what the patient is having, just give an antihistamine like diphenhydramine what is mentioned here. Once the symptoms are better, then you can restart the transfusion. What about in anaphylaxis? In anaphylaxis, the treatment remains very much similar what we have learned in your resuscitation chapter. There are absolutely no changes. But do not start the transfusion again. If you start the transfusion again, the next time around, the anaphylaxis might be so severe the patient even might die. So do not start the transfusion at any cost in this patient. How does an anaphylaxis present? More than two or more systems will be involved. For example, there might be shortness of breath along with some skin rash, some itching might be there, hypotension, tachycardia. Those are the common symptoms what you see in anaphylaxis. The another common presentation of an immune-mediated reaction is fever. Whenever there is a fever, we have three differential diagnoses what we are having. One is acute intravascular hemolytic reaction. This is life-threatening. This is also known as ABO incompatibility blood transfusion. What do I mean by this? Someone who is A B positive or someone who has a blood group of B, you ended up giving an A blood group. This is ABO incompatibility. It is an incompatible blood group what you're giving to this person can result in severe reaction, that is severe hemolysis. The hemolysis will be so severe that usually these patients die. That is the complication what we are expecting in an ABO incompatibility. It is also known as acute intravascular hemolytic reaction. So these patients will present with a fever very much soon. As soon as you start, these patients will start spiking temperature. Patient will start complaining that he's having pain at the site of the infusion itself. Some low back might be there. He will be in shock and there might be hemoglobinuria. So in the exam, how do you expect? There is a fever plus the patient is unstable for you. Then it is an acute intravascular hemolytic reaction. In how do we treat this patient? Stop the transfusion immediately, start on IV fluids so that there is some amount of intravascular fluid remaining inside the blood itself and basically supportive management. There's no specific treatment what you can give here. Next most commonest is the febrile non-hemolytic transfusion reaction. Here also febrile, so fever will be present. Along with it, the patient will be stable. That is major differentiation between an acute intravascular hemolytic reaction and febrile non-hemolytic transfusion reaction. Here the patient is stable. The vital parameters will be stable. There will be no hypertension will be seen. Only fever with chills. Usually it takes few minutes, at least few minutes to develop, if not hours to develop after the start of the transfusion. What do you do? Stop the transfusion again here. Initially, it might be a little bit confusing between the acute intravascular hemolytic reaction and febrile non-hemolytic transfusion reaction. That's why you stop the reaction and check the vital parameters and see whether it is an acute intravascular hemolytic reaction or not. Usually, we tend to get and routine investigations also done at that point of time. Wait for the investigations. Do not restart the transfusion in these patients. For fever and chills, you can use paracetamol to treat. The another presentation which can be is known as delayed extravascular hemolytic reaction. Extravascular, it is not inside the vessels the hemolysis is happening. Where does it happen then? It happens either in liver or in the spleen. It is called as delayed. So it is as delayed as few days. It is not presenting immediately. So you are given the transfusion. Yesterday I had a transfusion. Today I am having a fever. Then you are suspecting a delayed extravascular hemolytic reaction. Most of the time you would have either admitted this patient or discharged this patient. Most of the time when you are doing a blood transfusion, you end up admitting this patient. So unlikely this to be seen in the emergency department. So whenever there is a fever, three differential diagnoses. One is acute intravascular hemolytic reaction where the patient is unstable. Another one is febrile non-hemolytic transfusion reaction where the patient is stable. Delayed extravascular hemolytic reaction, presentation itself is delayed. Treatment remains symptomatic. There is no specific treatment for a delayed extravascular hemolytic reaction. These are all immune-mediated reactions. So immune-mediated reactions can present as an allergic reaction or with a fever. Fever has three differential diagnoses. We already learned about it. Now we are entering into a non-immune-mediated reaction. They usually present with a shortness of breath. If the patient is having a shortness of breath after initiation of a blood transfusion, what are the possible reactions what you are thinking about? One is transfusion associated circulatory overload. For example, the patient is a known case of heart failure, or the patient is a known case of CKD, or the patient is known case of nephrotic syndrome. In this patient's fluid overload is very commonly seen. If you give a small amount, if you give 250 ml also, fluid overload can happen. So this fluid what you're giving, that means the blood what you're transfusing to the patient goes into intravascular space. So intravascular volume increases and the patient will have and fluid overload symptoms. The most common one is the pulmonary edema, what we are worried about. So the patient will be having shortness of breath. Along with there will be some pedal edema might be there, some tachycardia, some hypertension might be there. How we treat and pulmonary edema in the similar manner here also we treat it with diuretics. Furosemide is the preferred one. The incidences of this has come down because when we are transfusing the blood in an heart failure patient or a CKD patient or a nephrotic, for example, any patient in whom we are suspecting a fluid overload is a possibility. Usually we give a low dose of furosemide before we transfuse itself or along with the transfusion. For example, a 20 mg of furosemide is given at the time of initiation of the transfusion. So he passes enough urine, so intravascular volume comes down as you infuse intravascular volume, that is as you start transfusion of the blood products. Another one is transfusion related acute lung injury. This is nothing but ARDS. It is very much similar to ARDS. It is an acute lung injury which is happening. Why is it happening? We don't know. There is no understanding of what exactly goes wrong here. But the prognosis is quite good. So within 96 hours, this patient kind of develops, they kind of return back to their normal self. So they recover within 96 hours. Sometimes because this ARDS might be so severe, this patient might require an intubation also. So transfusion-related acute lung injury is nothing but an ARDS, what we are having. We do not know what is happening. Supportive management, sometimes intubation might be required. Prognosis is good. They usually improve within 96 hours. So these are the transfusion reactions. What do you need to be aware of for the exam? Which one is most commonest transfusion reactions? Most commonest are two, that is circulatory fluid overload or a febrile non-hemolytic reaction. Out of these two, if at all, if they ask you or want you to choose one, I advise you to choose febrile non-hemolytic reactions because these incidents have started coming down, mainly because we have started using furosemide before we transfuse in this patient. For that reason, these incidents are coming down. So febrile non-hemolytic reaction is the most commonest one. Next one, we are getting into clotting factors and basically intrinsic pathway and extrinsic pathway of coagulation cascade. So what happens? There is something known as intrinsic pathway. There is something known as extrinsic pathway. Intrinsic pathway are usually activated when the inner part of the vessels are damaged. So intrinsic, inner side of the vessel is damaged. When the externally the vessels get damaged, for example, there is a trauma and a vessel get damaged. That is an external injury what the vessel is having. Then the extrinsic pathway gets activated. So these are the two pathways which gets activated. Basically, this pathways make sure that there is a clot formation and there is no excessive blood loss from that blood vessel. So what happens? Eventually, they come down to factor 10. Factor 10 gets activated, converts into factor 10A. Factor 10A converts prothrombin to thrombin. That is nothing but factor 2, activated form of factor 2. Factor 2 converts fibrinogen into fibrin and a clot is formed. Where does the warfarin act? Warfarin acts on the extrinsic pathway, specifically on 2, 7, 9, 10 are the clotting factors where it will be acting. These are the clotting factors which are synthesized by vitamin K. Hence, vitamin K will be one kind of an antidote for an warfarin overdose. That's why, because these clotting factors are vitamin K dependent clotting factors. Vitamin K is required for the synthesis of 2, 7, 9, 10 clotting factors. Most of the time, the antidote is PCC, prothrombin complex concentrate, what we'll be giving, because PCC has clotting factors 2, 7, and 9, and 10 clotting factors are present in PCC. That's the concentrate of the 2, 7, 9, 10 clotting factors. Where does the direct oral anticoagulants like rivaroxaban, apixaban, edoxaban acts on? They directly act on factor 10A and inhibit the factor 10A. Antidote for direct oral anticoagulants is adiponectin alpha. Where does an unfractionated heparin acts on? Unfractionated heparin acts basically or mainly on antithrombin 3 and activates it. Antithrombin 3 has an inhibitory effect on factor 10A. Along with it, it inhibits activation of 9, 10, 11, and 12 clotting factors. Compared to that, low molecular weight heparin acts on antithrombin, activates the antithrombin 3, which in turn deactivates the factor 10A, and it also deactivates factor 2. What about fondaparinux? Fondaparinux just acts on antithrombin 3. It doesn't act on anything else. Only on antithrombin 3. It activates antithrombin 3. And in turn, it will deactivate, antithrombin 3 will deactivate factor 10A. So what is the antidote for an unfractured heparin? Protamine sulfate. What about low molecular weight heparin and fondaparinux? It is adiponectin alpha. Where does an dabigatran act on? These are all anticoagulants I am talking about. The dabigatran acts on thrombin. Thrombin is also known as factor 2. What is the antidote of dabigatran? Edarizumab. This is asked multiple times in the exam. So you need to be aware of where does this anticoagulants act on. We have discussed various anticoagulants in the same slide here. One is the warfarin, one is the direct oral anticoagulants, unfractioned heparin, low molecular weight heparin, fondaparinux, and dabigatran. What are the antidotes of all this you need to be aware of? So let us see each. What are the tests which is required for you to really know if intrinsic pathway is affected or extrinsic pathway is affected? If APTT is prolonged, we are expecting the intrinsic pathway to be affected. Similarly, if PT is prolonged, we are expecting the extrinsic pathway to be affected. So whenever an extrinsic pathway is affected, PT is prolonged. Whenever an APTT is prolonged, you need to suspect that there is an intrinsic pathway which has been affected. So APTT is required for monitoring of an heparin in hemophilic patients. In an DIC and liver disease, it affects both the pathways. So it comes in both PT and APTT, both are prolonged in DIC and in liver diseases, because liver is required for synthesis of most of the clotting factors. Vitamin K deficiency, extrinsic pathway, because warfarin, vitamin K, here also warfarin, vitamin K. So extrinsic pathway, what do you need to think about whenever there is a PT prolongation? First one we are seeing of warfarin. Warfarin, we already know that it acts on, or basically it acts on vitamin K factors 2, 7, 9, 10. They are, and vitamin K is also known as phytomenadin. The main antidote is PCC we are aware of. But when to give PCC and when to give vitamin K? PCC stands for prothrombin complex concentrate. When to give vitamin K and when to give PCC? So it depends on what is the presentation. There is no bleeding, Minor bleeding example or classical example is a nosebleed, or it is a gum bleed what you are having. So epistaxis or a gum bleeding, if they're presenting, it is a minor bleed. Classical example for a major bleed is intracranial hemorrhages. Okay, along with it, any GI bleed. Most of the time, it is the upper GI bleed we are worried about. It can be a lower GI bleed also. It will be considered as a major bleed. Minor bleed is epistaxis or the gum bleed. No bleeding is absolutely no bleeding is there. Warfarin requires an INR monitoring. So you get an INR levels done. There is no bleeding for some other reason, or a routine INR investigation was done, and you come to know that the INR levels are between 5 to 8. What you do? Stop the warfarin for a few days. Once it comes down, then you can restart it. If it is less than 5, you need not do anything. If it is more than 8, stop warfarin along with it, give oral vitamin K. If there is a minor bleed, and if it is less than 5, don't do anything. If it is between 5 and 8, stop warfarin and give intravenous vitamin K. If it is more than 8, stop warfarin and give intravenous vitamin K. So for minor bleed, the treatment is stop warfarin plus IV vitamin K if the INR level is more than 5. That's the simple. In a major bleed, it remains the same. It doesn't depend on the INR at all. So in all, you'll stop the warfarin, you will be giving IV vitamin K, and you will be giving PCC. This is the basic management. Here, one more thing you can see that PCC or FFP, what I mentioned. Why have I mentioned FFP? If prothrombin complex concentrate is not available, you can use FFP. This is nothing but fresh frozen plasma. This will have all the clotting factors, including 2, 7, and 9, 10. So if this is not available, which is the ideal one, then you will be giving FFP in these individuals. Sometimes in your stem of the question, they might mention it as stop warfarin as one of the options. Another option will be giving vitamin K per oral. Another option will be giving vitamin K IV. Another option might be giving PCC. How do you pick up? Which one is the right one? So it is a major bleed we'll be considering. In major bleed, the first one to be given is PCC. The second one to be given is vitamin K intravenously you'll be giving. The third step is to stop the warfarin. So in this sequential order, you will be picking up the right one. If PCC is given, pick PCC. If this is not given, pick vitamin K. If this is also not given, then pick stop warfarin. So you should be picking up in this priority order. Unfractionated heparin. Unfractionated heparin, as we know, it directly acts on antithrombin 3. It activates this enzyme. This in turn will deactivate factor 10A. Along with it, 9, 11, and 12 factors are also deactivated by unfractionated heparin. What is the advantage of unfractionated heparin? The advantage is it has a very rapid onset. Especially in emergencies, it is very helpful because it has a very rapid onset. And it can be given in intravenous form. So it is helpful in emergencies. The problem with it is it has a very short life. Because it has a very short half-life, it has to be given TID, or it has to be given in an infusion form. You cannot discharge this patient on the same drug because he needs to inject himself in the intravenous form for 3 times or have an infusion. So this is not a kind of preferred drug to discharge on. Along with it, this acts very invariably. The concentrates in your blood will be very fluctuating over the time. So APTT levels are very important. It needs to be monitored closely. And it is safe to be given in renal diseases. Quite safe. Whenever there is a renal disorders, we prefer giving an unfractionated heparin. If there is an overdose or started bleeding, someone who is on unfractionated heparin started having a major bleed, then you want to reverse it. You can reverse it by giving an protamine sulfate. Low molecular weight heparin. Low molecular weight heparin, as I told you, again, it acts on antithrombin 3 enzyme, which basically it activates it, which in turn deactivates factor 10A. Along with it, it also deactivates factor 2. It has a quite longer half-life, so single dosing can be done for the patients, so it is helpful. Response is quite predictable, so routine APTT investigation will not be required in these individuals. So you can discharge these patients. It can be given subcutaneously, so kind of a very good drug. Fondaparinux, we have learned about fondaparinux in an NSTEMI. Along with an aspirin, we end up giving an fondaparinux for the patients. Where does this drug acts on? This drug acts on antithrombin 3. It only inhibits factor 10A. Okay, so it basically activates antithrombin 3, which in turn deactivates or inhibits factor 10A. Only it doesn't, any other factors it will not inhibit. So what are the reversals all together put together here? Fondaparinux as a first line give adenosine alpha. Same thing holds good for direct oral anticoagulants as well as low molecular weight heparin. you will be giving adenosine alpha as in first line. Second line will be PCC prothrombin complex concentrate will be given for fondaparinux and direct oral anticoagulants. For low molecular weight heparin, protamine sulfate is the preferred one as a second line drug. As a first line for unfractionated heparin, it's protamine sulfate. Dabigatran is idarucimab. Second line is PCC. Third line is dialysis. What about thrombolytic agent like altiplase you are giving or tenecteplase you are giving? If you're given the thrombolytic agent like an altiplase in last 24 hours, then you can reverse it by giving an cryoprecipitate in the first hour, first line of the drug. Second line of the drug remains tranexamic acid. Is there a role of activated charcoal? Yes, there is a role of activated charcoal in direct oral anticoagulants if they have consumed this tablet within last 6 hours. After 6 hours, it is not preferred, mainly because it would have all been observed and it would have been in the bloodstream. So giving an activated charcoal is waste here. In dabigatran, if they have consumed dabigatran in last 2 hours, then you can give an activated charcoal. So this is the summary of reversal of anticoagulants, what we have learned so far. There is a new test which has come up, which is kind of challenging the coagulation profile, what we get it done. In coagulation profile, usually we'll be seeing an PT, APTT, INR, then you'll be having a bleeding time, clotting time, platelet counts, what we'll be having. This is altogether is known as clotting profile. Now, in few of the trauma centers, they have started using something known as thromboelastogram, which is kind of readily available in the sense it is similar to an ABG, how you perform it. So you collect a blood sample, you have a machine which is available in the ER itself. So you will get the results quite immediately. Within few minutes, you'll be having. This takes approximately 45 minutes to get the results. So it is quite faster you can get these results. But it has still proven clinically, it has to prove itself. Though theoretically it might be better than the traditional coagulation profile what we'll be giving, but still studies are required. It is not very commonly used. It is not commonly used in all the trauma centers. Only few trauma centers has it as of now. So as this is a new evolving investigations, they might test you in the examination. So be aware of it. How to look at this? This is a diagram which usually comes up with. This usually suggests that how speed the clot is forming. This basically suggests that what is the strength of the clot which is present here. This LY30, what you are seeing, it is the speed of thrombolysis, what you are seeing in these patients. Now we are entering into the blood products. You need to be aware of blood products before I talk about a massive hemorrhage protocol. What are the blood products which we usually use? One is the PRBC, what we'll be using. PRBC is nothing but it has the RBCs in it. Why don't we use an whole blood and why just use an PRBC? Whole blood cannot be stored for a very long time in the blood bank. That's why whole blood is divided into different products. Okay, whole blood is either whole blood, PRBCs is separated, plasma is separated, and platelets are separated. So platelets are different, RBCs is different, plasma is different. They separate the whole blood into RBC, platelet, and plasma and store it. It will have a longer shelf life. They can store it for a longer duration. For that reason, whole blood is not included in a major hemorrhage protocol. What is fresh frozen plasma? It is basically in plasma what we are having. It has all the clotting factors. So main thing you need to remember, it has all the clotting factors which is present in this. Usually 6 units are given to rise about 20% of the clotting factors. What is cryoprecipitate? Cryoprecipitate is a derivative of an FFP. It is derived from an FFP that is known as cryoprecipitate. Cryoprecipitate, if the fibrinogen levels are on the lower side, then you give cryoprecipitate to increase it. So it increases by around 1 gram per liter if you give 5 units of pooled cryoprecipitate. What is prothrombin complex concentrate? It is also derived from FFP. As I was talking till now, it has 2, 7, 9, and 10 clotting factors in it. It is mainly given for warfarin reversal. So now coming into major hemorrhage protocol, it is very important to understand what is major hemorrhage protocol. In our trauma class, we keep on saying that we'll activate major hemorrhage protocol, we'll activate major hemorrhage protocol. What is major hemorrhage protocol? Whenever you are suspecting a significant blood loss, okay, it is very difficult to say whether the patient has lost significant amount of blood or not. You cannot quantify it, but we can guess in a patient, yes, this patient has a significant amount of blood loss when the patient is having a low systolic blood pressure. we are definitely sure that in this patient, there might be a significant blood loss. We might need to transfuse the blood in this patient. That's when you'll go ahead and activate the major hemorrhage protocol. Once you activated the major hemorrhage protocol, that means basically we'll call the blood bank and ask them to activate the major hemorrhage protocol. According to the major hemorrhage protocol, they will send you the blood products. It takes some time to send it from the blood bank to the emergency department. In the meantime, what you'll be doing, you will be having gaining a two large IV cannulas. Collect the blood samples for full blood count, blood group, cross-matching, coagulation profile, fibrinogens. This has the blood sample has to be sent to the blood bank as soon as possible. In the meanwhile, if it is an trauma case, start giving tranexamic acid if they are presented within 3 hours, followed by an infusion of 1 gram over an 8 hours time. What about in postpartum hemorrhage? In postpartum hemorrhage, 1 gram of tranexamic acid bolus can be given. What about in GI bleed? It is not recommended. Remember this, it is not recommended. Tranexamic acid is not recommended in GI bleed. I had said this point in gastrointestinal chapter. I'm repeating this again here in our oncology and hematology chapter. No tranexamic acid in upper GI bleed. In trauma, it is preferred if they're present within 3 hours. That is important. Once you get the blood products, what you will do? First, you will do whether do I have the lab reports available. Most of the time, lab reports will not be available because coagulation profile will take around 45 minutes for it to arrive or for it to give the results. Meanwhile, while you're waiting, what you will do? You will transfuse the PRBCs and FFPs. So 1 unit of PRBC you will be giving followed by 1 unit of FFP in the ratio of 6:4 what you will be giving. So 6 units of PRBC to 4 units of FFP what you will be transfusing. Or you can give in this ratio PRBC to FFP to platelet 1:1:1 ratio. 1 unit of PRBC to 1 unit of FFP to 1 unit of platelets can be given. This is what preferred in or this is what is recommended by ATLS. So what I recommend is follow this one, that is 1:1:1 ratio for a trauma case. For a medical case, follow 6:4. Usually in emergency departments or the recommendation given by British Society of Hematology, what is the recommendation given? Each hospital should have its own protocols. So a protocol should be preset how you need to transfuse it. This will be continued. The same ratio will be continued till the lab results are available. Once the lab results are available, then you will be having a closer look at the hemoglobin, INR level, fibrinogen level, and platelet counts. If the platelet counts are less than 50,000, then transfuse the blood. If the fibrinogen levels are less than 1.5, transfuse the cryoprecipitate. Fibrinogen increases by transfusion of cryoprecipitate, which is an extract of an FFP. If INR is on the higher side, that is more than 1.5, transfuse FFP because it has the clotting factors. Falling HP in an active bleeding patient, you'll transfuse an PRPC. So actively bleeding, hemoglobin might not be less than 7. Usually we transfuse blood when the hemoglobin levels are less than 7. But if there is an active bleeding which is present and the patient is hypotensive, go ahead and transfuse PRBCs in those patients. The best fluid to restate in a trauma case is PRBC. Because if you just transfuse the IV fluids, there is loss of RBCs which are present. RBCs are very important for you because those are the vehicles which will carry the oxygen to various parts of your body. If there are not enough RBCs which are present, just having a fluid there, it will cause dilutional anemia and eventually that will be disaster for the patient. That's why PRBC is the best fluid to transfuse in a traumatic patients. How long will you continue this cycle? You will continue this cycle, all these parameters come in the normal range and the bleeding has stopped. Both parameters has to be met. Once the bleeding has stopped, HB is okay, quite acceptable, that is more than 7, bleeding has stopped, INR is less than 1.5, fibrinogen levels is more than 1.5, platelets are more than 50,000, then you stop the transfusion. This is known as major hemorrhage protocol. What is von Willebrand's disease? In von Willebrand's disease, there is a deficiency of von Willebrand factor and factor 8. Factor 8 is a clotting factor. Factor 8 is present in intrinsic pathway. Intrinsic pathway will cause elevation of APTT, increase or high levels of APTT. Von Willebrand factor is required for bleeding, required to stop the bleeding. So the bleeding time increases. It basically helps in aggregation of the platelets. 1 millibrand factors helps to makes the platelets quite sticky and form or stop the bleeding there. So bleeding time. So whenever there is an increased bleeding time and increased APTT, then suspect this patient to have an von Willebrand disease. This is an hereditary coagulation disorder. How do you treat it? Mild patients, you treat it with desmopressin. Severe patients, you treat it with cryoprecipitate or factor 8 concentrate, whichever is available. Factor 5 deficiency, it kind of acts on the common pathway. So PT and APTT both are elevated. In fact, sorry, in hemophilia A and hemophilia B, hemophilia A, factor 8 is affected, hemophilia B, factor 9 is affected. So in both scenarios, APTT will be high. PT will be in the normal range. It will not affect anything platelets at all. So it will be in the normal range. Hemophilia A is an X-linked recessive disorder. Mild cases can be treated with desmopressin. Severe cases, we usually transfuse the factor 8 itself, concentrate if it's available. If that is not available, you can just give an FFP because we know that FFP has all the clotting factors. Same treatment here also. That means ideally in an severe cases, we'll be giving factor 9 concentrate. If factor 9 concentrate is not available, then what you'll be doing, then you will be giving FFP. In mild cases, you will be giving desmopressin. Idiopathic uh, thrombocytopenia, what we are calling idiopathic thrombocytopenia. It is broadly classified into primary and secondary. Primary is not known. The cause is not known. If the cause is not known, it is known as ITP, idiopathic thrombocytopenic purpura. If the cause is known, usually there is an underlying cause is present. Most of the time, it is an autoimmune disorder or an infection is present. Then it is a secondary idiopathic thrombocytopenia. How do they present to the emergency department? They do not present with a major bleed. They present with a minor bleed along with some viral infection. Whenever there is a viral infection, usually the platelet counts comes low a little bit. It will be on the lower side because the platelet count is a little bit on the lower side because of the viral infection. And there is an underlying primary or and secondary idiopathic thrombocytopenia. This patient will start having bleeding, a minor bleeding, like bleeding from the nose or a petechial lash, bleeding from the gums, gingival bleeding, we call it. So this is a petechial rash, what you are seeing, that will be the presentation here. So what happens here? Low platelet counts already there. A viral infection predisposes or viral infection causes worsening of this low platelet counts, resulting in minor bleeding. They present to the emergency department. When you get and routine investigations done like in full blood count, then you find out that the patient is having an low platelets. How do you treat it? If this has an life-threatening bleeding, like an intracranial hemorrhage or an GI bleed is present, then you will transfuse platelets. If the if the platelet count is less than 20,000, then also you will end up transfusing the platelets. If not, you will be just treating with steroids and IV immunoglobulins. Most of the time, it is an autoimmune disorder. You need to control this autoimmune disorder. So steroids will be helpful. IV immunoglobulins will be helpful. Before I enter into the leukemia, I'll take up your questions. If trauma and bleeding more than 3 hours, will we not give tranexamic acid? It is not recommended to give tranexamic acid if it is more than 3 hours. So we'll enter into the leukemia. So leukemia, when do you suspect in leukemia? When the WBC counts are really on the higher side and you're not suspecting an infection to cause this one. For example, the WBC count is like 40,000, unlikely an infection to cause it. There is no fever, the inflammatory markers are fine, but the WBC count is skyrocketingly on the higher side. Suspect an leukemia. First thing what you'll be seeing in the peripheral smear. First thing what you'll be seeing, how much or how many blast cells are present. These are immature cells. How many blast cells are present? If the blast cells are more, that is more than 20%, then it will be acute. If the blast cells are less, then it is a chronic thing which is happening out. It is known as chronic. If blast cells are more than 20%, it can be ALL or AML. ALL is very commonly seen in children. It is associated with anemia, and lymphocytes are predominantly which are seen because it's ALL, acute lymphocytic leukemia. Lymphocytic. So lymphocytes are seen on the higher side. AML is very rarely seen in the children's, or it is usually seen in the adolescent age, and it goes into 20s and 30s, more commonly seen in 20s and 30s rather than seeing in the childhood. Childhood, it is an ALL for you. If it is in 20s and 30s, think of an AML. AML myeloblasts, they are present. Myeloblast. What are the myeloblast cells? So increased neutrophil counts, increased basophil counts, increased neutrophil, eosinophil, basophil counts, what you'll be seeing. On the peripheral smear, you might also be able to see the OR rods. Okay. That is important thing what you need to be aware of. If the blood cells counts are less than 20 and the patient is elderly, associated with lymphadenopathy or splenomegaly, always think of CLL, chronic lymphocytic leukemia. CLL, what you'll be thinking. So in an elderly patient, if the blood cell counts are less than 20, it's always CLL for you. No, it is not an elderly, it is not an 70, 80, 90 years old patients. Then you are thinking of an CML. CML usually seen again in 30s and 40s age group, you'll be seeing in this patient. So very rarely in the children's. The one thing you need to remember, it is associated with Philadelphia chromosome. It's a catchy phrase used in most of the PLAB exams and USMLE exams, can be tested in your MRCAM exam also. Associated with low platelets and splenomegaly. To summarize, what you really need to look out for is if the WBC counts are really high, you are not thinking of an infection, look at the blood cell count. If the blood cell counts are more than 20, it is an acute leukemia what you're having. If the blood cells are less than 20, it is a chronic leukemia what you're having. We call it as an ALL if it is in the pediatric age group. We call it as an AML if it is in 20s and 30s age group with the blood cells being more than 20. Along with it, remember about the OR rods. If the blood cells are less than 20, we have CML or CLL. CLL is seen in elderly 70s, 80s in that age group. Usually what they say, do not treat CLL. There might be some other disease and he'll die because of that disease rather than dying from an CLL. So we usually do not treat the CLL at all. CML. CML is commonly seen in again 30s, 40s, and 50s, that middle age group, what we'll be seeing. Remember Philadelphia chromosome for CML. What is myelofibrosis? Here, fibrotic tissue gets deposited in the bone marrow. So bone marrow is kind of replaced by the fibrotic tissue. So there is no bone marrow is present. If there is no bone marrow is present, RBCs cannot be produced, platelets cannot be produced, and WBCs cannot be produced. That's why these patients will be having pancytopenia. Hodgkin's lymphoma. Hodgkin's lymphoma, they usually present with B symptoms. Fever, night sweats, and weight loss are known as B symptoms. The pain will be severe when they consume alcohol. In laboratory investigations, especially on the smear, you can see Ritzenberger's cells are commonly seen, or pathognomic cells which are seen in Hodgkin's lymphoma. Most of these patients will present with swellings which are present. When you examine these are lymph nodes which are enlarged and they are asymmetrical. For example, left-sided cervical lymph nodes are enlarged. Next, you will be seeing right-sided groin lymph node, that is inguinal lymph nodes are enlarged. They're not symmetrical. Left and right side cervical lymph nodes are enlarged. It will not be symmetrical. It will be asymmetrical lymphadenopathy, which is painless, and it become painful on alcohol consumption. Associated with these symptoms, they'll be presenting. You'll be just referring them to the oncologist. You cannot do much. So you'll be suspecting an Hodgkin's lymphoma and refer to the oncologist. Multiple myeloma, again, you will suspect multiple myeloma depending on the presentations. Usually you can remember with a mnemonic known as CRAB, where C stands for hypercalcemia. Calcium levels are on the higher side. Renal failure, kidneys gets affected here. Along with it, there is anemia and bone lesions. Bones lesions are lytic lesions. Usually they present with pain in the bones. You get an X-ray done, you see a lytic lesion. You get a full blood count done, there is anemia also associated with it. In the routine investigations, creatinine is on the higher side. Then go ahead and get the calcium levels also done. The calcium will be on the higher side. So CRAB mnemonic is satisfied. You're strongly suspecting an multiple myeloma. Again, refer. You cannot do much in the emergency department. Diagnosis is usually done by monoclonal proteins in the serum and the urine. This basically what you're seeing is Benz-Jones proteins, what you'll be seeing. Sickle cell anemia is important. Most of the time, they present with a complication of sickle cell anemia rather than you diagnosing in sickle cell anemia in the emergency department. Sickle cell anemia is an autosomal recessive disorder. Okay, you need to be remember this. This is a congenital, it is an acquired, not an acquired disorder. It is transmitted genetically. It is an autosomal recessive disorder. There are two kinds of sickle cell triad we call it, and sickle cell anemia we call it. In sickle cell triad, only one gene is affected. In sickle cell anemia, both the genes are affected. If both the genes are affected, the hemoglobin which is present, the abnormal hemoglobin, that is HbS, we call it the abnormal hemoglobin because of sickle cell anemia. 80% of it will be an abnormal hemoglobin. In sickle cell triad, where only one gene is affected, 40% of it will be abnormal hemoglobin. So sickle cell anemia is quite worse because it has two genes which are involved and 80% of the circulating hemoglobin is sickle. What happens? What is the basic pathophysiology? Whenever their body is exposed to an acidic environment or deoxygenation, hypoxia, they're exposed to hypoxia or an acidic environment, the RBCs will start sickling. So what do I mean by sickling here? So the RBCs, when they are exposed to an low pH or they are exposed to an low PaO2 values, they become sickled. Once they are sickled, the flexibility of it is lost. As the flexibility of it is lost, they get broken down or they get stuck into the smaller capillaries or they get stuck into the reticuloendothelial system, like they get stuck into the spleen most commonly, resulting in obstruction, as well as they get broken down into multiple fragments, they get broken down. Okay, so RBC's lifespan will come down from 120 days to as less as 10 to 20 days because of the sickling effect, what we are seeing here. So if they go ahead and get occluded in smaller capillaries, vaso-occlusive crisis will appear. Infraction will start happening and they will have severe pain. Any infraction will have severe pain. It is a cry from the organs that they are dying. Hematolytical crisis, basically this can get sequestrated. All the RBCs can get stuck into the spleen and suddenly this patient can have a massive anemia. Sorry, severe anemia, this patient can have it. Aplastic crisis, we have studied in our dermatology chapter. Whenever there is a power B19 infection, a cheek, slab cheek-like kind of rash will be there, especially in sickle cell anemia patients, can resulting in aplastic crisis. Infections, they're predisposed to infections. Why they're predisposed to infections? Spleen is present. Spleen goes auto-infarction because over the time inside the spleen, the sickle cells gets obstructed in the spleen and this part of the spleen gets died. Some part of the spleen gets died over the time. So spleen is not functioning or functional asplenia will happen. Because of functional asplenia, what will happen? Spleen is required to kill the capsulated organism. So it cannot kill the capsulated organisms anymore. So what are the capsulated organisms? What do you need to be aware of? For example, streptococcal pneumonia, what you can remember, Klebsiella pneumonia, you can remember, Pseudomonas aeruginosa, you can remember. These are all capsulated organisms. Even Neisseria meningitis is a capsulated organism. Pseudomonas, strep pneumoniae, Klebsiella, all are capsulated organisms. They get predisposed to this capsulated organism because spleen is not functioning. So in this patient, that's why meningococcal vaccines are very much recommended. They have to get the meningococcal vaccines. What are the key part of the history? Is there any precipitating factors? Because we are looking for what? We're looking for basically this patient is having an hypoxia, a reduced pH. Might be because of a fever, might be because of an dehydration. This can occur. That's why precipitating factors you need to look at. Ask for where is the pain. Pain is the most commonest presentation in a sickle cell disease complication. Pain is in the limbs, chest, back, abdomen. Where is the pain? Is the pain quite typical or it is a different in characteristic? Is there any neurological symptoms? Because this sickle cells can go into the brain and can cause an stroke. Is there any shortness of breath associated? Or for that matter, is there any lung symptoms present? Any lung symptom the patient is having, always think of an acute chest syndrome in this patient. A sickle cell disease presenting with any respiratory symptoms, it is an acute chest syndrome until and unless proven otherwise. So it can be any symptom like in chest pain, for a shortness of breath, cough, hypoxia, wheezing, any symptom. Acute splenic sequestration is another complication what we can see where large amount of RBCs get accumulated in the spleen because they are sickle, they trapped in the spleen. Spleen suddenly gets enlarged because all the RBCs are there. The hemoglobin levels will fall down drastically intravascularly. So intravascularly, the hemoglobin level has come down because the RBCs have come down. All these RBCs are present in the spleen here. That's why the spleen size gets bigger and bigger and bigger. Can result in hypovolemia and thrombocytopenia also in this patient. Osteomyelitis, as we have learned, the most commonest organism causing an osteomyelitis is Staph aureus. In sickle cell disease, it changes to Salmonella. Salmonella is the most commonest organism. What do you need to remember? What are the investigations? Again, all the routine investigations. You'll be getting a chest X-ray done to look for acute lung injury, acute chest syndrome. CT scan, if there are any symptoms suggestive of a stroke or any focal neurological deficit. Even myocardial infarction can happen, but it is very, very rare to see that ECG. Blood gas to see hypoxia. Liver function test is important because sickled RBCs breaks down. If they break down, what do they release? Hemoglobin. Hemoglobin breaks down and end products will be bilirubin. Bilirubin will be increased. That's why LFT is required. Blood films to see sickle cell RBCs. Full blood count mainly to see hemoglobin levels. Also, WBC is important because they are predisposed to capsulated organism infection. The main management. What is the main management of any complication who the patient presents to the emergency department with a sickle cell disease? Is pain management. To stress this, I have put this one. RCAM is also stressing a lot that pain management is the mainstay or the main thing what you need to look out for in a sickle cell disease. Usually, the sickle cell disease patients will have an pain management plan in hand with them. They will come and give you a piece of paper which has how to manage the pain in those particular patients. You will just follow what is given here. Otherwise, you will, most of the time, they will be having a severe pain. So you will be managing the severe pain how we are learned in our anesthesia chapter. So treatment, oxygen. Oxygen, we give it if the patient is hypoxic. Before, the thought was there to give oxygen to every patient who has sickle cell disease, because hypoxia is one of the causes or one of the triggering factors for sickling of the cells, sickling of the RBCs. But the latest recommendation is if they are hypoxic, then only give it. If they are not hypoxic, it doesn't make sense to give oxygen supplements because that is not the cause for sickling of the cells. Intravenous fluids, if required, give it. Usually oral will be preferred. Ask him to drink plenty of fluids. Most of the time they have severe pain, IV opiates will be required. If there is severe anemia, for example, splenic sequestration is present, at that point of time, blood transfusion might be given. Empirical antibiotics is given for every individual. Exchange transfusion. What is exchange transfusion? Entire intravascular volume of the blood is removed and replaced by another blood. Replaced by the blood. Okay. Same group of blood, what you'll be replacing with. This is known as exchange transfusion. Exchange transfusion is reserved for severe cases. For example, acute chest syndrome cannot be symptomatically managed or the patient is having a stroke. You will consider an exchange transfusion in priasim and you will consider an acute splenic sequestration. You'll consider, you will consider an exchange transfusion. Priapism, most of the time what we have learned in our urology chapter will be dealing in that manner. Okay, it's a last resort to use an exchange transfusion to treat sickle cell disease complication. Remember that cholelithiasis is a known complication of a sickle cell disease. Do not forget cholelithiasis is commonly seen in sickle cell disease patients. Now we are entering into DIC, disseminated intravascular coagulation. DIC, what happens in DIC? In DIC, there is activation of coagulation system. So once there is activation of coagulation system, coagulating factors, what will happen? Clot will form. Once there are plenty of clots which are forming. So clots are formed, plenty of clots are forming. So decreased in coagulation profile or clotting factors, decrease in clotting factors will be there. This decreasing clotting factors can result in increased bleeding. So these patients can have increased bleeding. These patients can have increased clot formation. Increased bleeding might be because of activation of fibrinolytic system also. So increased bleeding is seen because of decrease in clotting factors and activation of fibrinolytic system. Along with it, because there is activation of coagulation system, increased clotting is also seen. So these patients can present with two extreme presentations. This patient can have it. Can have it. One is hypercoagulability state. Lot of thrombos are present. Lot of clots are present. Hypercoagulability. Or it might be hyperfibrinolysis, bleeding. He's bleeding from everywhere. He's oozing from the catheter. He is bleeding from his GI tract. He's bleeding from his urogenital tract. So he can start bleeding from anywhere. So this bleeding is very commonly seen in leukemic patients. Hypercoagulative state is very commonly seen in sepsis patients. What are the causes for DIC? DIC has plenty of causes. Anything which is severe can cause an DIC, which stands for disseminated intravascular coagulation. So infections, bacteria, viral, fungal infections, carcinomas, traumas can cause it. Pregnancy like HELLP syndrome, amniotic fluid emboli, snake bites, Acute hemolytic reactions can cause it. Even ARDS can cause it, or acute lung injuries can cause it. So there are various things. Even severe pancreatitis also can cause an DIC in these patients. So anything which is very severe can result in an DIC. So lab investigations, what were we expecting? So usually low platelets, prolonged PT, fibrinogen levels usually on the lower side, what we'll be expecting, but can be on the higher side also. For example, DIC can also be seen in acute intravascular complications, acute complications of massive transfusion. Fibrinogen levels are on the higher side. If you see the first slide, I have written as an higher side. So higher side can also be seen fibrinogen levels on. D-dimers are usually on the higher side. APDT will be usually prolonged. So how we will be treating these patients? It's just a symptomatic treatment. You will be looking at the blood parameters and treat the blood parameters. For example, this patient is having a lot of thrombus which is forming. Consider giving low molecular weight heparin. Is this traumatic related? Consider tranexamic acid might be required in these patients. If PT is prolonged, give vitamin K. If PT and APTT are prolonged and low fibrinogens are level, FFP will be the best one to give it in this patient. Low platelet, that means less than 50,000 platelet transfusion you'll be giving. Okay, if the precipitating factors, depending on the precipitating factors, you need to treat the precipitating factors. For example, if there is an infection, antibiotics, dehydration, fluid resuscitation might be required. So accordingly, you will be treating. So what is the main treatment here? Symptomatic treatment, look at the blood investigations and transfuse the similar things what are required. Or if it is a thrombotic events what are prominent, then you will be giving or thinking of giving a low molecular weight heparin. The mainstay of the treatment is just treat the underlying cause, what is there, which has precipitated this. For example, if it's an infection, give antibiotics and treat the infection. If the infection can be treated, along with it, DIC also will get will come under control. Before I go into the back pain, let me take a few questions if there are any. Antibiotics in sickle cell patients, we give it as an empirically in every patient. Antibiotics are preferred to be given empirically in every patient. Red flags for back pain. What is red flags for back pain, or why has it come up with? Back pain is one of the most commonest presentation to the emergency department. So every patient we cannot do an imaging, and every patient we cannot end up admitting. So what we have come up with, red flags. If red flags are present, we will investigate. That means we will be getting an imaging done for this patient. That's why we'll be looking for this red flags. Red flags is if the possible diagnosis is a vertebral fracture, a tumor, or a spinal infection, cauda equina, AAA, or there is a pre-existing inflammatory rheumatic disease. Accordingly, you'll be look the symptoms for this probable diagnosis. If present, those are the red flags for us. We will further evaluate that patient. Otherwise, we'll be doing pain management and sending him home. On discharge, the preferred analgesia is NSAID according to the NICE guidelines. Monotherapy with NSAID. Before it was NSAID plus paracetamol. Now they have changed it to only monotherapy of NSAID. First thing, vertebral fractures. Vertebral fractures, obviously severe trauma, severe impact is there, then a fracture will be seen. But a trivial injury also can cause an vertebral fractures if the patient is on steroids, because it can cause osteoporosis. Similarly, in an elderly people, there might be a pre-existing osteoporosis. In those patients, a trivial injury can result in a fracture. So look out for this signs and symptoms. If you're expecting a fracture, then you can get an X-ray done, okay, or an CT scan done depending on the local protocols. Tumors. Whenever you're suspecting a tumor, always look for is there an weight loss present and extremes of the age present. History of malignancy might already be present in the patient. In the stem of the question, they might use a known case of prostate. Then suspect it might be a metastasis of the prostate CA, what is present in this patient. So metastatic spinal cord compression, what this patient is having. Or there might be a primary tumor in the spinal cord itself. So suspect this whenever there is a weight loss and extremes of the age is present. Spinal infection, what we are studying in the in infectious diseases chapter about epidural abscesses. Spinal infection, I'm talking about abscesses. Epidural abscesses have become very common because of increased in IV drug users. So closely have a look for is this patient is an IV drug user in the stem of the question. Along with it, if the patient is having fever, it is an abscess, it is an infection. If there is a fever, should be present abscess. See, high grade fever or high grade temperature is expected in these patients. Cauda equina, we'll be studying more about the cauda equina in coming up slide, but classically what they do, they present with. Classically, either with bowel or bladder incontinence or a constipation or, constipation or an urinary retention they present with. Saddle anesthesia means numbness around the perianal region, around the anal region, and lower limb neurological neuropathy will be seen in lower limb. That is bilateral and symmetrical it will be. Triple A commonly seen in elderly individuals. They will be systemically unwell. We'll be studying more of this triple A in the vascular chapter here. Triple A, most of the time, anyone more than 55 years age group presents to the emergency department, we usually get an bedside ultrasound scan done to see the diameter of the aorta. This will help us to think about AAA and see if the aorta diameter is on the higher side. That's when we think of getting an CT scan done, that is CT angiogram, CT aortogram to get it done in those individuals. If required, if unstable, will be involving the vascular surgeons. We'll be studying more about this in the vascular chapter. The main inflammatory rheumatic disease, what we are thinking about is ankylosing spondylitis. In ankylosing spondylitis, we have a bamboo spine, which is quite brittle, commonly seen in less than 20 years age group. Structural deformity, that is the bamboo spine seen, they are very prone for fractures. Other than you are thinking of a fracture, for example, you are thinking of an CA, you are thinking of an abscess, you are thinking of an cauda equina syndrome, you're thinking of an cauda equina syndrome. In those circumstances, you will go ahead and get an MRI scan done. Do not do an X-ray. X-ray is useless. Most of the time, X-ray is useless. Okay, if someone comes with a back pain, I'll get an X-ray done. To see what? You'll not see anything on an X-ray. So X-ray is useless. They advise you to go ahead and get an MRI scan done unless and until you're suspecting a fracture where you can see it on a CT scan or X-ray. What are the clinical features which are suggestive of a nerve root pain? A pain which is radiating from your back all the way to your foot or toes. And numbness in the distribution of the nerve compression. For example, it is an S1. So all in the distribution of the S1, there will be numbness. It is the L5, it is the S1 or S2 is involved, L5, L4 is involved. Depending on where is their distribution, accordingly, the numbness is also seen. For example, this is the where S2 is present, S1 is present, L5, L4, L2. Numbness will be in that distribution accordingly. Straight leg test, that means a person is made to lie down flat and you will raise his leg straight up. That is knee in the extension. You'll be raising this leg. You can worsen the pain or the pain can be elicited in this. Local neurological in the distribution of the nerve root will be present. What is sciatica? Whenever there is an impingement of lumbosacral nerves, this can cause compression on the nerves. That is, impingement is there, compression is there. So the pain will radiate from right from the back up to the foot. It will be radiating. This is known as sciatica. Most of the time, the impingement is seen in L4, L5 or L5S when the impingement is seen. So again, as I told you, depending on the which dermatomal distribution is there, numbness will be seen in those dermatomal distributions you need to be aware of. Risk stratification tool endorsed by NICE is Neil Starr's back risk assessment tool. You can just ignore it. Not very important from exam point of view. This is important. What is metastatic spinal cord compression? Metastatic. So primary tumor is a secondary tumor which is present there. It has metastasis from a primary tumor. For example, see a prostate. It has metastasized into a spinal cord. Or it has metastasized into a vertebrae usually. Then it causes or spreads into the spinal cord. Most of the time, metastatic spinal cord compressions will have pain in the thoracic and cervical region rather than in the lumbar region, unless you are suspecting a prostate which has caused a metastasis. So usually they present with a localized spinal tenderness will be there. Pain will be exaggerated or aggravated by straining. Nocturnal pain preventing the sleep might be present in this individual. What we will be doing whenever you're suspecting a metastatic spinal cord compression, what you will be doing? Most of the time, they'll be already be knowing as known case of CA, they present with an back pain. Now you're suspecting a metastatic spinal cord compression. Compression means there should be some neurological deficit. So what you'll be doing? Get an MRI scan done directly. Do not get an X-ray, do not get a CT scan done. They are useless. Whole MRI, whole MRI spine, you need to scan it. Why whole? Because if metastasis in the cervical, it can be in the thoracic or it can be in the lumbar region also. For that region, whole spine needs to be scanned, not an individual segment where he's complaining of the pain. And this scan needs to be done within the 24 hours. As I told you, no X-rays needs to be done. Pain management needs to be done. Nursing should be in the neutral position, that is in the flat neutral position, you need to do it. Why these patients develop neurological deficit or why these patients have the pain? Why do they develop pain? pain is developed because of developing of the swelling around it. Okay, edema is developed. Edema, basically swelling, that causes compression over the spinal cord. This results in the pain what they are presenting with. This compression can be relieved by giving steroids. The sooner the steroids is given, the better it is. So in emergency department, your role is to get the steroids going, or you this bolus steroid, that is dexamethasone 16 mg stat for this patient as soon as possible. You need to discuss early with the oncology team as well as with the neurosurgeons, because the sooner you decompress, the better the prognosis will be. Cauda equina syndrome. Again, whenever there is a back pain, we always think, can it be a cauda equina? Can it be a cauda equina syndrome? Cauda equina syndrome is compression of the nerve roots below the level of spinal cord. That means it is basically compression on the conus medullaris. Once the spinal cord ends, after this, there are nerve fibers which runs downwards from lumbosacral region. They runs downwards. This appears like an horse tail, which is known as conus medullaris. So compression on this results in cauda equina. So it can be compression because of anything like a disc prolapse, trauma, tumors, epidural hematomas, trauma, epidural abscesses. So it can be anything which is causing compression over conus medullaris. Clinical features depend on which is the nerve which is compressed. But classically, how do they present? Classically, bladder disturbances. That means the patient might be having acute urine retention. This patient might be having, or urinary incontinence might be present. Involuntary urinary incontinence. Bowel disturbances also commonly seen. This patient can be having constipation or bowel incontinence. He has opened his bowel without his consciousness. Bowel incontinence can be seen. Along with this, what else is seen? Perianal anesthesia is seen, and pathology is seen in the lower limbs. Usually, it is symmetrical pathology which is seen in the lower limbs. Get an MRI scan done immediately. Specialist reference should be done. Here, you're not waiting for 24 hours, or within 24 hours, we are not telling you. Here, you need to get the MRI scan done as soon as possible, because there is a compression over the conus medullaris. The sooner the compression is relieved, the better the prognosis is. So immediate MRI scan done and refer to the spinal surgeons. Neurosurgeons also can operate on the spine. Most of the time, particularly, there will be spine surgeons refer to the spine surgeons. Bladder control, a little bit more about the bladder control, what you need to be aware of, might be tested. Most of the time, it is tested in the primary. Bladder is controlled by parasympathetic and sympathetic. Sympathetic intervention is from T10 to L2 level. Parasympathetic intervention is from S2 to S4 levels. Next, bladder. Bladder has detrusor muscles. If detrusor muscles contract, the volume of the bladder decreases. That's when you get an urge to pass the urine, and you relax yourself voluntarily. You will be relaxing the external sphincter. Involuntarily, internal sphincter gets relaxed whenever you have the urge to pass the urine. Involuntarily, internal sphincter will relax on its own. Parasympathetic. What's the function of parasympathetic? Helps you to pass the urine. Parasympathetic. When you're relaxed only, you want to pass the urine. So you go, you want to pass the urine. Yeah, you feel like bowel is full. I'm having the urge to pass the urine. Let me go and pass the urine. Parasympathetic system will take over. There will be contraction of the detrusor muscle, relaxation of the internal sphincter, and voluntarily, once you are in the toilet, you will relax the external sphincter. That will result in passage of the urine. Sympathetic. For example, you do not want to pass the urine when you are under stress. A dog is chasing you. You do not want to stand and pass the urine. So you want to run and you are worried about rest of the things at that parameter. What will happen? Parasympathetic will take over. This will cause relaxation of the detrusor muscle. So more and more urine can get accumulated. And it will cause constriction or closure of the internal sphincter. External sphincter, anyways, it's an voluntary one. So what happens if there is a spinal cord injury? For example, if there is a spinal cord injury anywhere between S2 to S4 level, this is injured, then sympathetic system will take over. What is the function of the sympathetic system? The testosterone muscles relaxes, bladder volume will increase, and there is constriction of the internal sphincter. So more and more and urine gets accumulated here. But testosterone muscle is a muscle. It cannot infinitely keep on stretching. There is a limit to stretching. Once it reaches the limit, the pressure here starts increasing. Once the pressure starts increasing, the urine starts dripping out. The urine starts leaking because the pressure is so much high. This is known as underactive bladder. Now let us see what is overactive bladder. In overactive bladder, we are suspecting a spinal cord injury between T10 to L2 levels. Because the spinal cord injury is in this level, parasympathetic system will take over. If the parasympathetic system is taken over, function of it is to cause constriction of the detrusor muscles and relaxation of the internal sphincter. What will happen? It will become an overactive bladder. Every 5 minutes, you feel like passing urine. You go there and you pass some 5 ml. Because it is a small bladder, the volume is not much. Again, after 5 minutes, again, you feel like passing the urine. You go and open the bladder and you pass the urine. Only 5 ml is coming out. Those are the two functions. And depending on the lesion where is there, it can be overactive bladder or an underactive bladder. You need to be aware of. Tumor lysis syndrome, nothing but similar to rhabdomyolysis. Why do I say this? Tumor lysis is nothing but an cell. Rhabdomyolysis, this is also nothing but as it's a cell. It's a muscle cell what is present. Here it is a tumor cell. That's the only difference what you are having. Management remains same. Here also you will be giving IV fluids. If that is not working, you will be going for hemodialysis. Here you will be seeing high urea levels. Because tumor is a cell, cell is a protein has urea. The last end product is an urea. From inside the cell, phosphates are released, calcium gets deposited on the broken down cells. Inside the cell, potassium is there, potassium gets released. That will result in hyperkalemia. So nothing but rhabdomyolysis, what you need to remember, which we have already learned. It is similar to rhabdomyolysis, remember that. Superior vena cava obstruction. What happens here? Superior vena cava gets obstructed. Most of the time, superior vena cava is obstructed because of an apical tumor of the lung. This apical tumor, most of the time, it is a Pancoast tumor. So the apex here has a tumor. It has grown, caused the compression over the superior vena cava. Once the superior vena cava is compressed, collateral veins will open up. That's why you will see collateral veins will open up and the venous system or the venous blood cannot come down into the heart very much because the main vein itself is get obstructed. Most of it will come through the collateral veins. As you can see, collateral veins are quite distended here. Along with it, there will be swelling of the head, swelling of the neck, and swelling of the upper limbs is seen because venous flow from all these veins from the upper limbs, from your head, neck, everything drains into the superior vena cava, eventually will drain into the right atrium. That is obstructed. That's why you're seeing swelling there. How can they present with? They can present with some visual changes because swelling is there, swelling in the head, neck. Because of this, some visual changes, some dizziness, sometimes even some little bit of breathlessness also can be present in these patients. How do you manage or how do you diagnose this patient? Most of the time, it is a clinical diagnosis. If you're having difficulty, imaging might be required. Get an CT scan done or get an X-ray done to see any apical mass is there, which is causing compression over the superior vena cava. Supportive treatment. Acutely, they will have symptoms because of development of the edema. To treat this edema, you will be giving the steroids in these patients. Depending on what treatment is required, a radiotherapy or chemotherapy or a stent for a superior vena cava inside the stent because it hasn't compressed because of a tumor here, place the stent here and dilate it. That is one of the treatments. These are all chronic treatments. In emergency department, what can you do? You can do a supportive management and give steroids. Autonomic dysreflexia. It's a very interesting concept what is present here, which is known as autonomic dysreflexia, which is very commonly tested. It has similar question has appeared at least 4 times in previous diets. Okay, 4 times in previous diets it has appeared. What happens here? What are the prerequisites for an autonomic dysreflexia? There should be a spinal cord injury. Usually the spinal cord injury will be at a higher level. In the cervical or higher thoracic level it will be. So a spinal cord injury should be present. Along with it, this patient should be catheterized. So he should be on an Foley's catheter. Basically, urinary catheter should be present in this individual. So what happens here? The first thing is this urinary catheter which is present gets blocked, gets obstructed here. So block of urinary catheter will be seen in this patient. Next thing what happens? Because of the block in the urinary catheter, this bladder is getting distended. He has an urge. The pressure has increased. So what happens when you are in stress? He goes into a stress because he's unable to pass the urine at all. Whenever there is a stress, your autonomic system will take over and sympathetic system gets stimulated. So this is relayed through the spinal cord to the sympathetic chain. Sympathetic chain that is above the T6 level, usually the sympathetic, thoracic and cervical sympathetic, what we are talking about. Once this is activated, what will happen? So sympathetic chain is activated here. Mainly what it will secrete norepinephrine. What will norepinephrine cause? Non-epinephrine will cause severe vasoconstriction. Severe vasoconstriction will result in increase in blood pressure. So this has resulted in increase in blood pressure. This increase in blood pressure is picked up by chemoreceptors. Chemoreceptors are present in your carotid sheath, in arch of aorta, the chemoreceptors are present. It is picked up from the chemoreceptors. Then it is transmitted to your brain. In brain, it says, okay, we need to bring down the blood pressure. Blood pressure is very much on the higher side. Let's bring down this blood pressure. This blood pressure is bring down by what? Through the vagus nerve, it will ask the heart to reduce the heart rate. So heart rate comes down. Okay. Then it sends the impulses through down the spinal cord to all the peripheries to cause vasodilatation. But it is not possible. There is a spinal cord injury which is present here. So the nerve, no, so, sorry, the signals from the brain will not get transmitted below the level of the injury. So complete vasodilatation will not occur. Partial vasodilatation will occur. So blood pressure will be somewhere on the borderline, but bradycardia is seen. Why bradycardia is seen? Because the blood pressure is not adequately coming down. So brain is telling, bring down the blood pressure. Why is the blood pressure not coming down? Bring down the heart rate. Bring do an vasodilatation. Vasodilatation not happening because the signals are not passing down. Adequate vasodilatation is not happening. Some signals will come down till the level of spinal cord injuries. For example, upper limb, there might be vasodilatations. Abdomen, thorax, lower back, your lower limbs, vasodilation will not occur. And adequate levels of blood pressure will not be reached. So this is the sequence of things what you need to remember. So prerequisite is spinal cord injury and catheter will be present in your stem of the question. Along with it, they'll present with blood pressure within the normal range. Usually the blood pressure will be like 140 or 130 in that range. It will be 130 to 140 systolic blood pressure. And there will be a bradycardia. They'll ask you what is the diagnosis? Autonomic dysreflexia. What needs to be done? Remove the obstruction what is present. Change the catheter. Change the catheter, everything will come in the normal range. We will enter into the recall questions now. We have a 70 years old involved in a bar fight, sustained multiple injuries. On examination, the saturations are slightly on the lower side. Tachycardia, tachypnea, low blood pressure is present. The airway is patent. He started on high flow oxygen. 2 large IV cannulas are secured. IV fluid is started. You activated the major hemorrhage protocol. The patient has a history of AF on dabigatran. While waiting for the blood products, what is the next best step they are asking? While waiting for the best step, it's the best step to reverse the dabigatran which is present. So what is the reversal agent what you'll be giving for the dabigatran? The reversal agent for the dabigatran is idarucimab, what you'll be giving. This is the reversal agent what you'll be giving. An elderly male has presented to the emergency department with complaints of an lower back pain since a couple of days. There is a history of weakness in the lower limb since yesterday. On examination, the patient is having vital parameters within normal limits. You decide to get an MRI scan done. Due to the presence of red flag signs, MRI scan of the signs reveals an metastatic spinal cord. What is the next best step in the management? Metastatic spinal cord. What you will be doing? The best thing is to get an U and dexamethasone. Preferred steroid also you need to be remembering. It's a dexamethasone which is preferred, and the dose also you should be aware of. It is a 16 mg which is the preferred one. An elderly female recently had an burning maturation with an increased frequency of urination. So there is an infection, suspecting an UTI. GP has suspected UTI, treated with antibiotics. The patient has taken antibiotics for a day, but now she has developed a diffuse rash all over the body and complaints of generalized weakness. Her laboratory temperatures are as her laboratory reports are as follows: hemoglobin lower side, WBC on the higher side, platelets low, CRP on the higher side, INR is elevated, PTA, PTT also on the higher side, D-dimer is higher side. So everything is dearranged. What is it suggestive of? And DIC. What is the predisposing factor for an DIC? Unit tract infection. What is present here? Infection which has caused this one. So this is the diagnosis of an DIC because all the parameters are abnormal here. A 65 years old, basically they're asking what is the mechanism of action of dabigatran. Dabigatran acts on factor 2. Factor 2 is also known as thrombin. So the right answer here is it is a thrombin inhibitor, factor 2 inhibitor. A 76 years old female presented with shortness of breath, you evaluated and found her to be having an hemoglobin. So shortness of breath is because of low hemoglobin. IV line is secured in the left cubital fossa, started on blood transfusion. Soon after the blood transfusion, the patient started complaining of pain at the site of IV cannula. The vital parameters are checked. The patient is hypertensive, tachycardic, and less. And So what are we suspecting in this patient here? So we are suspecting an transfusion reaction. Transfusion reaction is suspected in this patient. Along with this transfusion reaction, is this patient stable or unstable? Is this patient is unstable? So which one is unstable? What we are seeing? Unstable is seen in acute intravascular hemolytic reaction. This is an acute intravascular hemolytic reaction what the patient is having here. Clear? Circulatory overload, they'll be presenting with shortness of breath. Anaphylactic reaction, more than two systems will be involved. Here, it is not the case. Infection and sepsis on the cannula takes time. Extravasation of blood will not present, will not cause hemodynamic instability. Which one of the following is an antidote of rivaroxaban? What they are asking. Basically, antidote of rivaroxaban, what they are asking. Out of this, the antidote of rivaroxaban is adenosine alpha. A 3 years old child was brought to the emergency department by his parents. There is a history of slip and fall, and while he was playing with his cousin and sustained an injury to the head. His past history is significant for hemophilia. There is factor 8 deficiency. On examination, he has a scalp hematoma measuring around 6 centimeters, and there is a bruise over the chest also. The patient is tachypneic, tachycardic. Blood pressure is fine, saturation is fine. What is the most appropriate next step in the management of this plan? Is there an indication to get an urgent CT scan done in this patient? No, there is no indication to get an urgent CT scan done in this patient. Okay, there is no indication for the CT scan to be got it done on an urgent basis. So what needs to be done? Hemophilia is present. The patient is having a scalp hematoma, which is quite large, around 6 centimeters. To stop the bleeding, what we usually do, along with it, there is a chest bruising also present. Give factor 8 for this patient. So factor 8 is the right answer for this. Chest CT scan is not required in this patient on an immediate basis because the vital parameters seem to be all right. Doesn't suggest you of much of a respiratory cause here because the saturations are 100% on the room air. This has appeared in Feb 24 also. A 70 years old present with an ED, sorry, September 24. This September 2024 died. A 70 years old male presents with ED with complaints of palpitations. He is connected to the cardiac monitor, showed signs tachycardia. Blood investigation shows that hemoglobin is very much on the lower side. You decide to start the transfusions. After 45 minutes of blood transfusion, the vital parameters are as given below. Vital parameters seems to be stable, but the patient is having high temperature. What is the most likely diagnosis here? Fever is present. So we have three differential diagnoses for in fever if this present. It can be delayed. It is not delayed because blood transfusion is going on. So you rule out and delayed. Acute intravascular hemolytic reaction, unlikely because the patient is stable here. So it is more likely and febrile non-hemolytic transfusion reaction. So the first one is febrile non-hemolytic transfusion reaction is the right answer. A 46 years old male has brought to the ED department with complaints of pain, vomiting, which contains blood. So upper GI bleed what this patient is having. On examination, there is tachycardia, there is tachypnea, low blood pressure is present, fluid resuscitation has been started, blood investigation shows an hemoglobin of 50, fibrinogen level of 1.8, platelet of 80,000, INR of 1.2. What is the next best step? So we need to transfuse here. Major hemorrhage protocol needs to be activated and transfused. According to the major hemorrhage protocol, once laboratory investigations are there, you need to transfuse according to that. So, does this patient requires an cryoprecipitate? No, not required. Cryoprecipitate is not required. Platelet count is not less than 50,000 give platelet transfusion. INR is not more than 1.5 to give to be thinking of an FFP transfusion. Hemoglobin is on the lower side and we are suspecting an active bleed in this patient. So, giving PRBCs is the best one. That is nothing but giving 10 units of RBCs also means PRBCs. P stands for packed RBCs. This also has appeared in September 24. A 8-week pregnant lady present to the emergency department with complaints of headache and sweating. Her past history is significant for spinal cord injury. There is a resultant paraplegia. She is on long-term catheter. No urine is noted in the uro bag. Also, no urine is noted in the uro bag. That means there is an obstruction to the catheter because she is on long-term catheter. Also gives an history of not opening the bowel since last couple of days. Our observations are as follows. Significant bradycardia is present in this individual. So, is the criteria satisfied? Is there a spinal cord injury? Yes. Is there a catheter block? Yes. Is there a low heart rate? Bradycardia is present? Yes. If all three are present, what are we suspecting? Autonomic dysreflexia. One of you was asking, can headache and sweating can be present? Sympathetic. Whenever there is activation of sympathetic system, everything gets whatever you see, there is a high temperature can be seen, all those parameters can be seen, a sweating can be seen, headache can be seen in these individuals, even seizures can present with these patients. So various presentations can be seen, but they are not specific for an autonomic dysreflexia. This triad if present, then you are thinking of autonomic dysreflexia. 8 years old boy, a known case of hemophilia A, was brought to the MS department by his worried parents. He was playing in the backyard with his friends when he fell and had an injury to his head. He continuously bleeding from the scalp even after applying the pressure. This is an important phrase here. In ED, you are not able to stop the bleeding with an external pressure. Which one of the following will help to stop the external pressure? He is an hemophilia A. Hemophilia A is factor 8 deficiency, what you are having. In factor 8 deficiency, we transfuse factor 8. Factor 8 is given here. We are giving factor 8 for this patient. A young male was involved in a road traffic accident. Paramedics interpreted the patient at the scene and brought to the emergency department in an ambulance. On arrival, he has been received in the resuscitation bay connected to the cardiac monitor. His observations are as follows. The important one is hypotension, what is present here. You started with fluid resuscitation and you are given some blood products also to his BP has improved to 90/60 only. However, the patient continues to have an heart rate on the higher side. What is the next best step? This involves your trauma class, major trauma class, what you have learned about the resuscitation. So, is there a response here? The blood pressure has improved from 70/40 to an 90/60. Yes, there is an improvement. Does this patient eventually will require blood transfusion? Yes, will be requiring blood transfusion. Do we have enough time to wait for PRBC, which is cross match? Yes, we do have, because the blood pressure has improved with the fluid resuscitation. Do not give uncrossed blood for this individuals. Wait, give and cross match blood for this individual. So the right answer here is wait. Okay, this is a transient response, what you are seeing. This was learned, the responses was there, a transient response was learned in a major trauma where we said that if the blood pressure has improved, wait for the cross match blood. An elderly female present to the ED with complaints of an PR bleed. So we are suspecting a GI bleed. She has noticed that weight loss, there is a significant weight loss also is present. Again, whenever there is a weight loss, suspect NCA. No comorbidities on any regular, sorry, no known comorbidities, not on any regular medications. Her vital parameters are within normal limits. Lab investigations have been given here. Hemoglobin is on the lower side. Rest of the parameters where we see APTT is on the higher side. Normal bleeding time is present. What is the most likely diagnosis? This is a tricky question here. Okay, you can rule it out and come. Hereditary hemophilia is an elderly female, or would have been already been diagnosed. It will not be an presentation in the elderly. It will be presentation in an younger age group. You can rule it out. Factor 5 deficiency. Factor 5 deficiency will cause elevation of what? Both APTT and PT. Here, there is only elevation of APTT. There is PT is in the normal range. So this one also you can rule it out. Von Willebrand factor. In von Willebrand factor, bleeding time is in the normal range. Bleeding time is increased. Here it is in the normal range. So von Willebrand factor also we have ruled it out. CML, lymphocytes, WBCs should be on the higher side. It is not. You can rule it out. And again, in elderly, we are more thinking of CLL than CML. Acquired hemophilia. Can it be acquired hemophilia? Yes, that is the right answer. What has happened here? Per rectal bleed, PR bleed is present, plus weight loss is present. This is suggestive of an CA colon. CA colon can have an paraneoplastic syndrome. It can produce or cause an paraneoplastic syndrome. This can result in acquired hemophilia. This is known as acquired hemophilia. So the right answer is acquired hemophilia. Might be difficult to think in this lines, but at least rule it out. Some questions might be difficult. Rule out, you will come to a right answer. It shouldn't be difficult for you to answer in the exam. A 67 years old female brought to the emergency department in an ambulance. She's on antibiotics, antibiotics for an recurrent UTIs. Vital parameters shows tachycardia, blood pressure on the lower side, temperature is on the higher side, WBC count is high, platelet count on the higher side, CRP is high, APTT is high, PT is high, D-dimer is high. What is the most likely diagnosis? It's kind of a repeat question here. Because of infection, that is urinary tract infection, leaded to an DIC. DIC, remember that platelets can be on the higher side. Doesn't mean always on the lower side. But PT and APTT, most of the time it is on the higher side. D-dimer is usually on the higher side itself. So the diagnosis here is an DIC. A 6 years old boy was brought to the emergency department with multiple episodes of epistaxis and bleeding from the gums. What the patient has presented with. Platelet counts is only 100. That is basically 1 lakh what you are talking about. Bleeding time is prolonged. Whenever the bleeding time is prolonged, we need to suspect something is wrong with the platelet. What is the right answer here? Is the ITP. There is bleeding time can be elevated and low platelets can be seen in both of these conditions, TTP and HUC. HUC stands for hemolytic uremic syndrome. Thrombotic thrombocytopenic purpura stands for TTP. What is the differentiating factors in this both? Hemolytic uremic syndrome, as the name suggests, hemolytic. So low RBCs, anemia will be seen. This RBCs usually get stuck in the kidneys, so will cause acute kidney injury. Hemolytic uremic syndrome will cause thrombocytopenia. So HUS has an triad, that is low HB, that is hemoglobin, acute kidney injury, and low platelet count, what is seen. If for HUS, this is what is present. If you add up fever and CNS symptoms, it becomes an thrombotic thrombocytopenic purpura. Okay, that's the differentiating factors. None of those signs and symptoms are given here. That's why we're not selecting an HUS or thrombotic thrombocytopenic purpura. Both of these are extensively or very favorite topics in USMLE and PLAB exams. Can be tested in your exams. That's why I have brought it up here. Diseases, remember that how to differentiate it. In ITP, HUS, and TTP, bleeding time will be elevated. Hemophilia only ATP will be elevated. APTT will be elevated. One bilirubin factor along with APTT, bleeding time will be on the higher side. So the right answer here is ITP. A young male presented to the ED with a lower back pain, numbness over the right foot since a couple of days. He denies any history of trauma. There is no significant past in medical history. He doesn't take any illicit drugs. His vital parameters are within normal limits. His neurological examination including anal tone, is unremarkable. What is the best next step they are asking? Few things. Here, the patient is having a low back pain and numbness over the right leg. Doesn't fit only on the right leg. There is a numbness. It can be a peripheral nerve which is getting involved rather than a spinal cord which is involved. So we are not sure about what is happening. But the neurological examination is completely fine, including the anal tone. So there is no red flags as such which is present in this individual. If there are no red flags, we can discharge this patient. That is one thing. We're not sure what the hell going on here wrong. So needs an MRI scan done eventually. So you can get an MRI scan done on the OPD side and discharge these patients. So third option is the right one. Because red flags are not present, that's why you're discharging. If red flags are present, you will further evaluate and admit those patients. Early symptom of CA prostate. Early symptoms, CA prostate it is. So prostate, in between the prostate, there is the ureter which passes, which can cause get compressed. So difficulty in maturation should be one of the earliest symptoms of an CA prostate. It is an outpatient urgent MRI scan. Read the entire line. A 34 years old male present to the emergency department with severe pain. He wakes up in the night because of the pain that is usually suggestive of severe pain. He doesn't have any known comorbidities. He is a known IV drug abuser. His observations are as follows. Temperature is on the higher side. Someone presents with an IV drug abuser, high temperature, and a lower back pain. What are we suspecting about? We are suspecting about an epidural abscess in this individual. Epidural abscess, what's the modality? We need to get it done. MRI scan. Never an CT scan or an X-ray will be useless here. A young postmortem lady present to the MS department with complaints of numbness of bilaterally lower limbs associated with lower back pain, weakness, generalized weakness since couple of days. Initially, she thought it might be due to the recent delivery, but the symptoms have worsened. She has not opened her bowel since a long time. She is just passing flatulence. Her vital parameters are stable. What is the most likely diagnosis? So what are we happening here? We are having an constipation the patient is happening. Along with it, there is a back pain. Along with it, there is lower limb pathology what is present. numbness, that is lower limb pathology. Keeping all this in mind, we need to think of an cauda equina in this syndrome. A 40 years old male who met with a road traffic accident was brought to the ED department in an ambulance. His observations are tachycardia, slight tachypnea, hypotension is present here. IV access is secured, 500 ml of RL is given, 2 units of O negative was checked, rechecked blood pressure is still on the lower side. Laboratory investigations are given as follows here. What is the next best step in the management of this patient? Let's see anything laboratory investigation. Platelets are not less than 50,000. INR is not more than 1.5. PT and APTT are kind of in the normal range itself. So what we'll be doing for this patient then? Hemoglobin is on the lower side. We are still suspecting an active bleed because the blood pressure is still on the lower side. So what we'll be doing? Continue giving PRBC for this patient because PRBC is the blood fluid for resuscitation. Elderly female presents with an history of increased frequency of maturation and decreased appetite on and off since almost a month's time. There is significant loss of weight is present. So I'm thinking of an CA here. There is no history of OCP in the lifetime. Remember that whenever the patient takes an OCP, if the patient is taking an OCP, it kind of protects against the ovarian cancer. It kind of predisposes against the breast cancer. Someone who is taking a OCP, most likely that this person is having a breast cancer. Unlikely that this patient is having an ovarian cancer if they are taking an OCP pill. On examination of vital parameters of within normal limits, our abdomen is soft and mass is felt in the left lower abdomen. Keeping all these in parameters, which CA are we suspecting in this individual? Because there is no OCP history is there, we can rule out an breast CA in this individual. Mass is not found in the center, it is at the side. Okay, it is at the left lower abdomen what you are having. So bladder CA also we can rule it out. Endometrial carcinoma also we can rule it out. So we are left with ovarian CA and colon CA in this individual. If there is an colon CA, usually they present with GI symptoms, something like an constipation or something like a rectal bleed. Most of the time, it is a rectal bleed what they present with a CA colon, not with the urinary symptoms. Urinary symptoms, whenever they are present, you need to think of something. It is in the ureter, sorry, something which is in the uterus or surrounding structures which is causing irritation to the bladder. Here, the surrounding structure is an ovary. It has enlarged and causing irritation to the bladder. That's why there is increased frequency of maturation in this individual. So ovarian CA is the right answer. Most common complication associated with massive transfusion is hypoglycemia. It's the most commonest complication because blood is stored in citrate medium. You are giving large amount of blood. Hypocalcemia is seen. Most of the time, it is not significant amount of hypoglycemia. Doesn't require any treatment. A 76 years old presented with a shortness of breath. On evaluation, you found the hemoglobin on the lower side. You got an IV cannula in. Blood transfusion has been started. Blood transfusion. She starts complaining of pain at the IV side. Recheck vital parameters are unstable or hemodynamically unstable the patient is. Hypoxic, hypotensive, tachypneic, tachycardic. So what are we thinking about in this patient whenever there is presented? We're thinking about acute, sorry, we are thinking about acute intravascular hemolysis. What it is also known as, it is also known as immune mediated. It is also known as immune mediated. Non-immune mediated or circulatory. It is not an anaphylactic reaction for sure. Infection and sepsis at the cannula cannot happen. Extravasation of blood cannot happen. It is an immune mediated transfusion reaction what you are having. Simply, it is an ABO incompatibility. A 66 years old female presents with a nosebleed. It is an epistaxis, which we consider as a minor bleed. She tried pinching her nose. She tried pinching her nose, which is unsuccessful for stopping the bleeding. You catheterize the bleeding spot with silver nitrate. She is a known case of AF. Her regular medications includes warfarin. You send the blood coagulation profile. INR has come as 6, so it is between 5 and 8. Which is the next best step? So this is in 5 and 8. It is a minor bleed. So coming to this and this, stop warfarin and give IV vitamin K. So which one is there? Omit one dose is nothing but stop warfarin. Give vitamin K. Both the right answers are present. If both are present, we'll always choose vitamin K over the stopping warfarin. So first step is always this, followed by this. When do we call it as a massive transfusion? What is the definition of the massive transfusion we are calling? When we transfuse more than 10 units of PRPCs over 24 hours, then we call it as a massive transfusion. He's a chronic smoker who presents with an face swelling and neck, swelling of the face, neck, and upper limb. He's a known case of hypertension, arthritis. All these parameters are within normal. Vital parameters are within normal. X-ray is given. What's the most likely diagnosis? So this presentation is suggestive of a superior vena cava obstruction or compression. Chronic smokers are predisposed to cancer. They are given here. They're given an X-ray here, which shows there is a mass at the apex. We are seeing an apical tumor here, which is causing compression or SVC, that is superior vena cava. So this should be an CA lung, what we are suspecting. This is the most commonest cause for obstruction of an CVC or a compression over an SVC. A 44 years old male brought to the MS department with complaints of mild abdominal pain, lethargy since morning, and no comorbidities on investigations. Lab values are within normal limits. Investigation shows WPC on the higher side, predominantly blast cells. Most likely diagnosis they are asking here. Predominantly blast cells, so it becomes acute for us. Next, what we usually see, age. If it is a child, then it is ALL. If it is not a child, then it is an AML. The age is 44, so we are choosing AML here. Patient with a CA prostate, you're suspecting and metastatic spinal cord. Which one of the following will be the first sign? Metastatics to the spinal cord will present with what? Pain. Pain should be the first one what will be presenting with. Usually they present with a pain. 13 years old, brought to the emergency department with a rash over the body. There is a history of sore throat and fever, and GP has treated symptomatically. On examination, there is a PTK which is present. So suggestive of an PTK and the low platelet counts is present. APTT is normal range, PT is normal range, INR, all this is in the normal range. Only the platelet count is on the lower side. Plus, there is an plausible viral infection with this history what we are having here. So what are we suspecting with? ITP, what we are suspecting here. So straightforward diagnosis, it is an ITP. Any of these factors are involved, PT or APTT would have been elevated, which is not seen here. So straightforward, it is an ITP for us with the options what they are given. A 66 years old female came in the came in with the complaints of rectal bleed since 2 to 3 days, associated with an dizziness, tachycardic, and the blood pressure is on the lower side. Lab investigations have been shown here. You have started blood transfusion. Soon after the transfusion, the patient develops chills and fevers. What is the next best step in the management? What you will do? They have not given recheck vital parameters. They have not given. So we are not sure whether it is the patient is unstable or the patient is stable here. So what two differential diagnosis what we are having, because the patient is having fever. So delayed it can be because it has soon. So it has to be acute, or it has either it has to be acute intravascular hemolytic reaction, or it has to be febrile non-hemolytic transfusion reaction. Either of this, the first step is always to stop the transfusion. Stop the transfusion, check the vital parameters. Depending on the vital parameters, if it is just febrile non-hemolytic transfusion reaction, give paracetamol. Once they are feeling better, then you can think of restarting the transfusion. If it is acute intravascular hemolytic reaction, no for transfusion. So the right answer here is stop transfusion. First step is always stop transfusion. Then if it is an acute, sorry, if it is an febrile non-hemolytic reaction, then you would have given the paracetamol for the patient. A 40 years old female came to the emergency department complaining of lower back pain associated with the weakness of the lower limb since last 2 to 3 days. This morning, she has not been able to hold the urine, resulted in urinary incontinence, which was very embarrassing for her. So urinary incontinence is present in this patient. She came to seek medical help. You suspect an cauda equina syndrome. Which one of the following will support your diagnosis? Which one of the following is seen in cauda syndrome? Shooting pain is more likely suggestive of sciatica. Weakness of one limb is not seen. Is a bilateral lower limbs which are seen. Pain radiating from back to the toe is again sciatica. Stiffness of the back is not very specific of cauda equina. Loss of anal sensation. Yes, it is seen. Along with loss of anal sensation, loss of anal tone is also seen. That's why we do an PR examination. Loss of penile tone is also seen in cauda equina. Remember that. That's why we do an PR examination in this patient to look at the anal tone. What we do is we insert a finger, ask them to squeeze it. If they're not able to squeeze it, the anal tone is decreased. That's how we check it. A 80 years old boy, a known case of sickle cell anemia, was brought to the MS department. He complains of chest pain, shortness of breath since morning. So anyone who has a sickle cell anemia presents with any chest syndrome, for us, what is the diagnosis? Acute chest syndrome unless and until proven otherwise. So it is an acute chest syndrome for us. Heart rate on the higher side, tachycardia, tachypnea, they're just asking which one is not included in management of acute chest syndrome. Do we give blood transfusion? Yeah, might be required. Analgesia, yes. IV fluid, yes. Antibiotic, yes. Empirical antibiotics is given to everyone. Bronchodilators are not given. So the right answer here is the first one. A 75 years old male presents to the emergency department after and fall onto an angle, sorry, fall onto the edge of the table 6 hours back. This is important, 6 hours back. He has a right upper quadrant pain. CT scan is shown that splenic laceration is present. The patient is having tachycardia and hypotension is present. Hemoglobin on the lower side, platelets is more than 50,000. INR is not less than 1.5. It is the major hemorrhage protocol is activated. 2 units of O negative blood has been transfused. What is the most appropriate next step in the management of this patient? 6 hours have happened. Tranexamic acid we are not giving. It should be less than 3 hours. 1 unit of platelet count is more than 50,000. You're not transfusing. 2 unit of FFP, INR is on the normal side, not required. PCC is not required. Again, here we're not thinking of warfarin or nowhere it is suggestive of an warfarin here. Transfuse O negative blood, yes, this is more appropriate because active bleeding, hypotension, along with hemoglobin on the lower side, transfuse additional O negative blood. The patient has presented with an hematesis and melena, so we are suspecting an GI bleed. Most likely, it is an upper GI bleed, what we are suspecting. The patient is having tachycardia, hypotension is present. Which one of the statement is correct? They are asking. Tranexamic acid should be administered. In GI bleed, we do not administer tranexamic acid, so the statement is wrong. Prothrombin, prothrombin complex concentrate cannot be given before INR is checked. Can we give the INR in this individual if the prothrombin, if the INR is on the higher side? We can give. Okay, it doesn't depend on the INR. If the patient is on warfarin and has a major bleed, then yes, you can go ahead and give warfarin to, you can go ahead and give PCC to the patient to reverse the warfarin effect. You do not check INR at all because this is a major bleed what you are having. So this statement is also wrong because you can give it without checking the INR. Platelet transfusion should be given if the platelet count is less than 50,000, not 60,000. Again, statement is wrong. Only O negative blood should be used in the initial resuscitation. Initial resuscitation, yes, it is correct. But later on, it is recommended that you have the cross-matched blood. Cross-match and specific blood, what you need to give it. So initial, yes. So this statement becomes right. Vitamin K should not be given due to the mechanical wall. No, that is not a contraindication to give an vitamin K. Still, you can give an vitamin K in these patients. A 19 years old female present to the emergency department with complaints of nosebleed. So it is a minor bleed what we are having here. She has a similar episode in the past. She has no comorbidities, not taking any regular medications, vitals are stable. On the lab investigations, you are having the following. What is the most likely diagnosis what they are having? So let us see the investigations what you are having. Platelets in the normal range, hemoglobin slightly on the lower side, WBC is fine. INR, normal range, only APTT is on the higher side. So APTT is prolonged. Bleeding time is increased. BT is on the higher side. Combination of this is usually suggestive of von Willebrand factor deficiency or von Willebrand factor disease. So fourth one is the right one. A 72 years old male present to the emergency department with complaints of lower back pain, which began a couple of days back and has worsened today. Upon further questioning, he reports that paresthesia, that is loss of sensation over the around the anal region accompanied with urinary incontinence. He denies any weakness of the lower limbs, has no prior history of similar complaints. Which one of the following is the most appropriate next step? What are we thinking about in these patients? We are thinking about the cauda equina. So cauda equina, what you are thinking? Red flags are present here because we are thinking of an cauda equina in these patients. That's why we need to get immediate MRI scan done for these patients and immediate referral to the spine surgeons needs to be done because the sooner the compression is relieved, the better it is. Especially in especially in cauda equina, it holds good. That ends here. Anyone has any questions, you can ask me now.